Hello, everyone. Thank you for joining today's third installment of the Alliance for Health Policy's Health Policy Roundup series, State Policy Analysis and Priorities. I'm Madeline Cree, Health Policy Analyst here at the Alliance. For those of you who are not familiar with the Alliance, welcome. We're a nonpartisan resource for the policy community dedicated to advancing knowledge and understanding of health policy issues. Today's briefing is brought to you in partnership with Arnold Ventures. You can join today's conversation on Twitter using the hashtag AllHealthLive and join our community at All Health Policy, as well as on Facebook and LinkedIn. Today's panel has a Q&A section at the end of the hour. We want you all to be active participants, so please get your questions ready. You should see a dashboard on the right side of your web browser that has a speech bubble icon with a question mark. You can use that speech bubble icon to submit questions you have for the panelists at any time. We'll collect these and address them during the broadcast. Throughout the webinar, you can also chat about any technical issues you may be experiencing, and someone will attempt to help. Leading our conversation today is Dr. Mark Miller, Executive Vice President of Healthcare at Arnold Ventures. Mark leads Arnold Ventures' work to lower the costs and improve the value of healthcare. He has more than 30 years of experience developing and implementing health policy, including prior positions at the Medicare Payment Advisory Commission, the Congressional Budget Office, the Centers for Medicare and Medicaid Services, the Office of Management and Budget, and the Urban Institute. Mark, we're so excited to have you with us today to guide this discussion, and now I'm happy to turn the stage over to you.
I appreciate that. Throughout the rest of this, I hope everybody just refers to me as Mark. Nobody's called me Dr. Miller for a long time, but I appreciate the intro. Just a little bit of orientation. Arnold Ventures is a philanthropy, meaning we give out grants for research and developing policy ideas and educating policymakers. We work at the federal and state level. We work on both sides of the aisle. Our agenda is driven by affordability, reducing the cost of healthcare or getting a better spend for the existing dollar. And we focus very much on the root cost, or the payers that are, truly paying the cost of healthcare in the end, the employer, the household, and the taxpayer, whether it's a federal or state taxpayer. Our research has led us to policy ideas that are market-oriented, but we also think there are many market problems and market failures, and so we also have policies that are more regulatory in nature. Some of our agenda includes the cost of drugs, market consolidation, and provider prices, particularly hospital prices, surprise medical billing, and the integration of Medicare and Medicaid for complex populations, the dually eligible populations. All of these have been implicated in one way or another at the federal level, but the objective today is to talk about these issues and related issues at the state level. And we have 4 speakers, and I'm going to introduce them now. And the speakers in order that they will be speaking, or the panelists, I guess, in order that they will be speaking. Maureen Hensley Quinn is the Senior Program Director of Coverage, Cost, and Value at the National Academy of State Health Policy. She oversees NASHB's portfolio of work that supports states officials related to issues on Medicaid, CHIP, state-based marketplaces. She also does work specifically around lowering prescription drug costs and healthcare system costs generally. This research and analysis is for around federal and state laws, regulations, and best practices. And she supports efforts to create and disseminate solutions to the states to increase coverage and to contain costs. Suzanne Del Banco is the Executive Director at the Catalyst for Payment Reform. Since its inception in 2010, Suzanne has led the Catalyst for Payment Reform in its commitment to help employers and other purchasers send a clear signal to the market about the need for higher quality and lower cost. Initially, they were focused on advancing payment reform. More recently, she has expanded their efforts to include price and quality transparency, benefit design, provider network design, provider consolidation and market power, and other topics. She has previously led the Leapfrog group. Colleen Becker is a senior policy specialist at the National Conference of State Legislatures. She specializes in prescription drugs and affordability issues. She tracks and analyzes legislation, writes policy publications, convenes and communicates that and provides technical assistance to legislators, staff, and other experts. Before NCSL, Colleen was a policy coordinator for the Chronic Care Collaborative, which advocated for people with chronic diseases in Colorado. Finally, Stephanie Anthony is a senior advisor at Manat Health, where she provides research, analysis, and advisory services on health policy and health law to public and private sector clients. She offers counsel on healthcare reform, Medicaid, CHIP, program design waivers, post-acute care, long-term services and supports. And she also advises on best practices for care management, integrated care models, and coverage options for the uninsured. So the way this is going to work is each of the speakers is going to go in order and speak for about 7 minutes. We'll move from speaker to speaker, holding questions until everybody has gotten a chance to get their opening comments out on the table. To get things going, I'll ask a few questions and get the panelists to start talking and get a little bit deeper on the comments that they've made. Meanwhile, we'll be accumulating questions from the audience and as quickly as possible move to those questions. So if everybody is good, then I think we'll move to Maureen as our first speaker.
Thank you so very much. I'm so happy to be able to join you all today. Really appreciate the Alliance and Arnold for inviting NASHB's participation. So I'll just kick us off and then hand it over to my esteemed panelists. To get us started, I just wanted to let folks know who may not. NASHP, or the National Academy for State Health Policy, is a forum for and by state officials. We aim to support state officials in addressing health policy issues across agencies and offices, since health policy really does live in multiple places. We are proud to be an Arnold Ventures grantee. We operate the centers on prescription drug pricing and health systems costs. So today, we're here to talk about how states are and others are addressing costs. Healthcare costs keep rising for all purchasers of care, including states, employers, health plans, and consumers. Over the past several years, there's been increased interest at the state level on what's driving these costs. The release of new and very expensive prescription drugs caught state leaders' attention, and increases in prices of existing drugs like insulin helped to spur substantial and varied state action. As you can see from this slide that my colleagues pulled together to highlight state legislative action on prescription drug pricing, again, that's aimed to reduce prices and costs. Between 2017 and 2021, so even during the pandemic, 50 states introduced legislation aimed at reducing drug costs. 49 states have enacted over 200 laws. You'll see, and I know this slide is a little busy, but there are themes across some of these efforts that states have made. What began as state interest in better understanding the drug supply chain and demanding transparent PBM or prescription pharmacy benefit manager practices is evolving into a sharper focus on drug prices. However, it is challenging to legislate or regulate lower price. With state guidance, NASHB has developed model policies to set upper payment limits on certain high RX drug costs, to reference price to Canadian pricing, the idea being importing the price rather than the drug, and even a model that finds unsupported price increases by a manufacturer. Also, over this past year, there's been an increase in state requests to understand prescription drug review boards. Such boards, if established, can be used to help leverage available data on prescription drug costs to inform policy, including potentially setting upper payment limits for health plans purchasing medications. Such limits are aimed to protect health plans and consumers. Again, a real focus on trying to get at the prices of the drugs themselves rather than looking throughout the supply chain for efficiencies. Although prescription drug prices have increased quickly over the past few years, by far the largest proportion of US healthcare spend is on hospitals, health systems, and high-cost providers. State leaders interested in addressing overall rising healthcare costs are looking holistically at what's driving spend and seeking solutions not only to address prescription drug prices, but also high hospital costs as well. So the next slide highlights very quickly some of the tools and policies, strategies that states are looking at right now. There are a growing number of states seeking the collection of detailed hospital price, cost, and financial data to inform their policy approaches. They are using that information in a variety of ways. As highlighted here, states are seeking authority to mitigate further consolidation or enforce anti-competitive contracting among hospitals and health systems, and health plans, which research shows helps drive up prices without improving quality. States are also seeking to adopt reference-based pricing, some using a multiple of Medicare's rate, which is aiming to constrain rising costs and also increasing cost predictability for health plans and state purchasers of care. Others are aiming to limit hospital rates through multiple levers, such as insurance rate review with affordability standards, or limiting or prohibiting facility fees, and more. State leaders are trying desperately to balance access, quality, and costs to achieve long-term health care and coverage affordability for individuals, families, and employers. NASHP anticipates that this activity will continue and evolve throughout 2022. And this last slide just highlights links to NASHP's centers, first on prescription drug pricing, then on health system costs, where we are supporting states in their efforts to address these costs while tracking what they're doing and sharing their progress. I look forward to handing it over to my co-panelists and for an in-depth discussion. Thank you all so much.
So Suzanne, you're up.
Hi, everyone. Very nice to be with you today as well. And thank you to the Alliance for Health Policy and Arnold Ventures for inviting me. I am the Executive Director of Panelists for Payment Reform. And if you go to the next slide, I'll share with you what I'm going to be speaking about. Actually, one more. And share with you the perspective I'm coming from. So Catalyst for Payment Reform, in case any of you are not familiar with us, has been around 11 years. We are a national independent nonprofit 501c3 organization, so primarily educational in nature. But we do aim to provide thought leadership to and coordination among employers and other healthcare purchasers who want to get better value for their healthcare spending. And as Mark said in his introduction to me, value being the best combination of quality and costs. What brought these purchasers together 11 years ago was the desire to see provider payment reform come to pass. And even though Mark described us as later coming into these other issues related to transparency and provider market power, later was about 2 seconds later, because as much as we would like to impact with provider payment reform, if we don't pay attention to all the incentives, both good ones and perverse ones that are in the healthcare system, it'll be sort of, a little drop in the bucket of change. So we have a membership, as if you look at the list of that you see on the slide here, we've got plenty of private employers, but we also work with a growing number of state Medicaid employee and retiree agencies, as well as multi-employer union trust funds, some universities, a nonprofit. And we have the 3 biggest benefit consulting firms that these purchasers turn to for advice in our membership as well, so that we can push them to be our evangelists, if you will, with our other clients. So together we work each year to create a shared agenda. And if you go to the next slide, we look at the healthcare system and say, what is it that's broken? What do we need to fix? And what can purchasers, by coming together in a critical mass, have a louder voice on, and therefore maybe some more influence or leverage in changing? So our main goals are effective payment reform and effective purchasers, helping them really be very sophisticated and progressive buyers of healthcare, as well as an effective marketplace. And what does that mean? One that has transparency, competition, where prices perhaps reflect quality, which almost never happens. So, we have lofty goals. We've been working away at them. I think we've come a long way with price transparency. Payment reform, we have a lot of it, maybe not so effective. And we still need to tinker there. But I do think that we have helped purchasers be a bit smarter about how they buy healthcare. So we work in a variety of ways to help bring that about. But let's now turn to the topic for today on the next slide. So in thinking about, what do we really need to have our eyes on as we look at what's happening with healthcare costs, prices at the state level, I think there's a variety of approaches to cost containment by purchasers. And when I say purchasers, I mean employers and other entities that buy benefits for, populations of people. And Maureen already shared some of these ideas because we see commonalities across both private employers and state purchasers. And in fact, when we started Catalyst for Payment Reform, we kind of thought it would just appeal to private employers, but states quickly came knocking on the door saying, hey, we buy in the commercial market too, and even Medicaid agencies, we're facing some of these same challenges. Let's share ideas together. So some of these apply, some of these ideas that are being tried apply more to private employers or purchasers who are working in the commercial market, but some of them apply across the board. So benefit design, as we've all followed, high deductible health plans really took off as a cost containment strategy. And frankly, they work in terms of the purchaser's expense. There's no question that they bring down the employer or purchaser's expense. However, over time, we've learned through research that they have some unintended negative consequences, like when people actually need care, they don't seek it because they're concerned about the out-of-pocket spending. And frankly, we know that most Americans don't even have enough money in the bank to cover their deductible. So at least the leading and sort of sophisticated purchasers that we work with at Catalyst for Payment Reform have started backing off on this. Some of them have also done reference pricing. And now when I say reference pricing in this context, I mean as it relates to the benefit design, not the payment to providers. And there has been some success here. Otherwise, provider network design has a lot of promise theoretically, but has never really caught on like the wildfire we thought it would. And it's been really contained to no more than sort of 20% of large employers who are using narrow or tiered or high performance networks or centers of excellence for specific services as a way to cut out the expensive providers and really connect their plan members to the high value providers. We see a little bit of direct contracting with healthcare systems, but it really takes a lot of bandwidth and sophistication that most employers don't have. And of course, provider payment reform. In some cases, it's saved a lot of money. I mean, look at TennCare and their episode-based payment. They have put out press releases about the money that they've saved. But I think, the quality impact of it, may be just as important. And there's other models that people are trying. None of them have been slam dunks. So if we go to the last slide, it's been interesting to watch ourselves in the arc of our experience at Catalyst for Payment Reform, start with really trying to support the use of market forces to affect change in the healthcare system and to really try to bring prices down, force transparency, improve quality. And while we have made some headway, it's very obvious that the playing field is not level. My son's a soccer player. They complain about field conditions all the time out here in California where there's not enough water. And so this analogy is really something I'm very comfortable with. There's too little antitrust enforcement out there to allow purchasers to have the same market influence that these consolidated providers have. And so the big question that I'm always asking myself is, will purchasers live with the angst that they have? Healthcare is too expensive. They've been saying this for decades. Is it worth it to them to just keep complaining, or will they get on the policy, train and say, hey, it is time for government to intervene and help us? And some surveys suggest that that's where they're heading. Although in my experience, most surveys that ask about the future and would you support policy in the future in a theoretical sense, often get support that doesn't materialize. But let's now turn to the last slide, where I'm just going to share some of the things that we're seeing around state policy interventions that I think could have legs. And I know my colleagues are probably going to mention some of these ideas, so I'll just touch them quickly. I think the policies that we're seeing are really intended to try to level the playing field, enhance competition where there is none, or force competition on the right things like the quality of care as opposed to prices, or to just directly contain prices. So if you look at Rhode Island, California, Massachusetts, Oregon, these are some of the states we hold up as models because they've figured out ways to understand what's happening in their marketplace and to tinker with things in ways that level the playing field a bit. But no one state has tried all these things at once. We have different states trying with bits and pieces. And so we're really pleased right now to have support from Arnold Ventures to think about what would be the ideal combination of policies that each state would have to have a really effective policy agenda in place that really can make the market work better. So with that, I will turn it back to you, Mark.
Okay, and Colleen, you're up.
All right, well, thank you all. It's also my pleasure to be here. And thank you to Alliance Health Policy and Arnold Ventures as well for the invitation. For those of you that are unfamiliar with NCSL, we are the bipartisan membership organization for all 50 state legislatures, Washington, D.C., and the territories. Our members include the 7,383 legislators and all 20,000 legislative staff. Our mission is to advance the effectiveness, independence, and integrity of legislatures and to foster interstate cooperation and facilitate the exchange of information among legislatures. So what NCSL does not do, though, is we don't take positions on issues, nor do we make policy suggestions, and we don't craft model legislation. So next slide. So as you can imagine, when it comes to how state lawmakers are approaching cost containment for prescription drugs, they're coming at it in a wide variety of ways. But I wanted to provide a few statistics for the audience to keep in mind during the discussion. So nationally, spending on prescription drugs accounts for about 9 to 10% of health expenditures, and that number has stayed relatively stable over the past few years. And as far as what states spend, approximately 5 to 10% of Medicaid spending goes to prescription drugs, but it also depends on the state. And then participation in the federal Medicaid drug rebate program means that every state has access to statutorily set rebates, but in exchange, state Medicaid programs must cover all drugs made by participating manufacturers. And then finally, for consumers, anywhere from 12 to 15% of overall personal health care spending goes to prescription drugs. But again, that number is a little squishy depending on the source. And you can find several studies that show patients are increasingly having a difficult time affording their medicines. So with that as our backdrop, I'd like to talk more about what steps states are taking to contain drug costs. And there's an enormous amount of momentum building and has been for several years. NCSL has been tracking prescription drug legislation since 2015 in our public-facing online database. It currently houses over 7,300 pieces of proposed and enacted legislation. And last year, we tracked over 750 bills, of which about 115 laws were enacted. Next slide, please. So for the purposes of today's discussion, I kind of grouped state cost containment strategies into 3 buckets. Those intended to impact state budgets, those intended to impact consumers' out-of-pocket costs, and then there are those that kind of apply more broadly and across both buckets. So tracking 7,000 bills, you can imagine the wide variety of policy approaches that legislators have taken. And what you're going to see on the slides is just a few of the trends we've seen over the past few years. But looking at these lists, it's important to remember that this isn't all of the options that legislators have considered, and that no policy is a one-size-fits-all. That said, many policy options listed have had bipartisan support across state houses across the nation. And I'm not going to go into each of these, but I wanted to highlight just a few. For states, alternative payment models have been generating interest, and I have 3 listed here, but there are definitely more options that states have considered. I have bulk purchasing arrangements listed, and what I mean by that is both aggregating prescription drug purchasing among state agencies and across state agencies. Importation is still percolating out there, and even though 8 states have importation laws, the state must first get their importation plan approved by the federal government, and thus far, those states that have submitted a plan have not received certification. So if I focus on the consumer column, many legislators have focused on reducing a consumer's out-of-pocket costs, and one of the most prominent examples of that is insulin. Of course, cost of insulin has been at the forefront of policy debates both at the state and federal level. And the most common state action is limiting co-pays for insulin, and 19 states currently have laws which limit that amount. And they range anywhere from $25 to $100 for a 30-day supply. And there's also been momentum around access to supplies such as continuous glucose monitors. And some states have even developed a state-run patient assistance program. And then the last thing I wanted to point out on this slide is, and something that's gaining legislative attention, is limiting the use of copay accumulator policies. And these are basically policies that limit the effect a manufacturer's coupon has on a patient's out-of-pocket costs, such as their deductible. Currently, 12 states and Puerto Rico have a requirement that any payment or discount made on or behalf of the patient must be applied to a patient's annual out-of-pocket cost sharing requirement. Next slide. And then there's more. PBM reform has consistently risen as a top concern for legislators, and that's pharmacy benefit manager reform. And last year, we tracked about 247 bills related to PBM reform. And that's about a third of total proposed prescription drug legislation. And about half of those were enacted. This is very much an area where we've seen bipartisan support, and there is a wide variety of policies states have pursued, but just highlighting a few here. A common approach is requiring PBMs to register or obtain licensure to do business in the state, prohibiting contractual gag clauses, which that would allow a pharmacist to disclose to a patient a cheaper alternative at the pharmacy counter. And even though that prohibiting gag clauses is now a federal provision, over 30 states have this type of legislation implemented, and we're seeing it already proposed for 2022. And a newer idea gaining traction is implementing a reverse auction process. And that's where a PBM competes, or PBMs compete for a state's business, and the lowest offer wins the business. And then, as Suzanne had mentioned, another option gaining traction is prescription drug affordability boards, or PDABs. And some folks are seeing these boards as having the potential of helping policymakers drill down on costs and really helping to find viable solutions. So 8 states have pursued this approach, and so far we're tracking 3 states for 2022. So, and then the last thing I wanted to mention is that over a dozen legislatures have enacted price and cost transparency laws, which require health plans, PBMs, manufacturers, and others to report certain pricing and cost information to the state. And even though that's not necessarily a direct cost containment strategy, it's definitely seen as a tool to inform lawmakers about which strategies to pursue. Next slide. So a question that always gets asked this time of year is, what can we expect from lawmakers looking forward into 2022 and beyond? But one thing that NCSL doesn't try to do is make predictions about the future. And if the past is any indication of the future, anything we speculate could very well go out the window. But here's what we do know, is that about 40 states in DC and the territories are back in session, and already we're tracking about 120 bills in 25 states. And we anticipate many more in the days and weeks ahead. We're already seeing many of the same themes and that I just mentioned, and the policies that I just mentioned, but of course with some variations. And then also 2022 is an election year, and over 6,000 legislative seats are going to be up for grabs. So as you can imagine, that typically assumes a lot of lawmakers' time. For that reason, it may deter some legislators from putting forth any legislation or legislation that doesn't have broad or clear bipartisan support or stakeholder support. But for other legislators, it can motivate them to put forth novel or interesting ideas. And then lastly, legislators are definitely watching what may, or more likely may not happen with the federal government. So of course, we had the Build Back Better Act that included several drug pricing provisions, but as many of you know, that has kind of stalled, and it remains to really be seen if any movements by the feds will happen on drug pricing in the coming months. So I just want to reiterate that this is just a snapshot of strategies states are pursuing, and lawmakers will really need to consider which ones will work best for their states and their constituents. So with that, I will pass it back over to you, Mark.
I appreciate that. Stephanie, you're up.
Okay, I think I'm here. Okay. Hi, everybody. Thank you, Mark, and thank you also to the Alliance and to Arnold Ventures for inviting me and Manat to this session. If for those who don't know Manat Health is an integrated legal and policy consulting and advisory firm that works across the country with clients across the healthcare spectrum. And I work in the long-term care space, mostly with states, but also with providers and health plans and other clients. And I'm going to buck the trend a little bit, and I don't have slides. I'm just going to talk. So I'm going to talk to you today about state initiatives and policies in 2021 that strengthen their long-term care systems, including both institutional and home and community-based services for older adults and people with chronic conditions or disabilities, and then also talk about some activity that's happening in 2022. So as you know, these populations who have been severely impacted by the pandemic because they're at higher risk for experiencing severe cases if they contract COVID, but also because they face disruptions in access to critical services if they or their caregivers get sick. The pandemic also illuminated and actually worsened some long-standing truths about our country's long-term care system, that it's direct care workforce, it's home health aides, personal care aides, certified nursing assistants, that workforce is struggling, it's under capacity, while the demand for these services that these populations use grows. The long-term care systems often operates in silos, disconnected from the rest of the healthcare system, and most of the beneficiaries, we learned this full force during COVID, that most beneficiaries want to receive care in their homes and communities rather than an institutional setting to the extent appropriate. So when we think about state activity in 2021, states kind of had their feet in two worlds, the present and the future. They were continuing to respond to the ongoing pandemic, whether it was by continuing to implement and monitor the impacts of the temporary Medicaid regulatory flexibilities that were granted as part of the emergency COVID relief. These are the, 11, I don't know to what extent people are familiar with these terms, but these federal waivers, 1135 waivers, Appendix Ks and such, that provided emergency regulatory relief so states could respond quickly and ensure seamless access to care for their populations. They were also, related to the pandemic, assessing federal PHE, public health emergency unwinding guidance that came out from CMS late in 2020, but then was updated in August of 2021 to begin to plan for the eventual end of the public health emergency and return to normal Medicaid operations, including ending the continuous Medicaid coverage requirements that were in the Families First Corona Relief Act. So states were focusing on that and actively participating in vaccination and testing campaigns. That was kind of the current world, but they were also looking forward a bit and strategically investing in strengthening their long-term care and long-term services and supports systems over a longer horizon by leveraging the American Rescue Plan's $11 billion in enhanced federal funding for state home and community-based services spending, which they can tap into through actually March of 2022, just a couple more months, they can tap into that enhanced FMAP rate. And then they can reinvest the freed up state dollars from that to support their COVID-related HCBS needs, home and community-based service needs, or HCBS capacity building and rebalancing efforts. And they can do that through March of 2024. So within this very dynamic framework, I'm going to highlight a few key activities around the country in 2021. So despite the pandemic continuing, some states have decided to make some select temporary Medicaid flexibilities permanent. For example, in March of last year, Arkansas revised its policies to expand its pharmacy scope of practice to allow pharmacy technicians to administer COVID vaccines and do other things. In September of 2021, Pennsylvania expanded the scope of services for which telemedicine may be used to include physical and behavioral health services. It also made audio-only telehealth a permanent modality, and it expanded the scope of providers who may render Medicaid services through telehealth. That was one big bucket. Secondarily, all 50 states and plus the District of Columbia worked to develop and submit their what was required from CMS, these so-called HCBS spending plans that enable them to leverage those enhanced federal dollars through the American Rescue Plan. So in 2021, states like Massachusetts, Minnesota, and Virginia put out RFIs, or requests for information, and conducted other stakeholder engagement activities to get broad input onto where they should invest these dollars going forward to strengthen their systems. The biggest, you can see all the state spending plans. CMS has a website, but when you look across them, they definitely bubble up into some key areas around provider rate increases, behavioral health service investments like mobile crisis services, direct care workforce supports like wages, recruitment, training, and education programs and retention programs, and health information technology infrastructure investments. Third, states continue to advance large policy initiatives that actually predated COVID, but were no doubt informed by COVID, including California, which finalized and negotiated with CMS an extremely large transformation to its Medi-Cal program. It's called CalAIM. It spans all aspects of the Medi-Cal program, plus, involve two waiver negotiations. And the reforms include care delivery and care management improvements for populations that use long-term services and supports, including institutional long-term care, people with behavioral health needs, and dual eligibles. Massachusetts and Vermont similarly were negotiating, developing and negotiating big 1115 waivers with CMS to continue, their delivery systems improvements for populations that include those who use LTSS. One last 2021 area I want to highlight is health equity. Stakeholders in Massachusetts and California supported work that examined racial and ethnic health disparities in their states and really identified significant gaps in race, ethnicity, and other demographic data collection and reporting that can be used to inform ongoing state discussions about advancing health equity. So those, those inputs will be important to those discussions in those states. So looking ahead to 2022, I'm going to highlight four main areas. One is going to be more post-pandemic planning. Second is going to be efforts to enhance care management programs for complex populations, primarily through managed long-term services and supports programs. About 25 states have managed care programs that serve long-term care populations and cover long-term care services. So there's some efforts there to really improve and enhance those care management programs. Some states are increasing focus on addressing social determinants of health, and then we're going to talk at the end about improved care delivery for dual eligibles. So quickly on the first one, just all states really are starting to more comprehensively prepare for the end of the public health emergency. It will end someday. Right now it's scheduled to end April 15th. I think the administration is committed to giving 60 days notice in advance of the end of the PHE, the public health emergency. So I think people expect it'll probably get extended a little longer, but eventually it will come to an end. And many states are starting to think about that and determine their approaches for restarting eligibility redeterminations and renewals after the, again, the Family First Corona Relief Act's Medicaid continuous coverage requirements end. When those end, states are going to have to redo eligibility redeterminations and renewals for collectively across the nation, millions of people. They're going to have to put notices out, outreach, so that's going to be a big endeavor for states. States are also thinking about how to unwind the temporary flexibilities that they were granted during the pandemic, but also, again, like Arkansas and Pennsylvania, starting to think about which ones they want to make permanent because they're just better policies. They realize that they worked well to produce better access or better care to folks, so that'll be a big bucket area. States are going to continue to focus on improving care management and care coordination for populations with complex care needs. This year, in 2022, North Carolina is going to launch what they call tailored plans, which are specialized Medicaid managed care plans for individuals with significant behavioral health needs, as well as intellectual and developmental disabilities and traumatic brain injury. Tailored plans are going to cover comprehensive state plan physical health, behavioral health, and long-term services and supports, as well as pharmacy, but they're also going to cover a broad array of home and community-based waivers type services and provide robust care management for, holistically across all the service needs of enrollees. Virginia is actually going to merge or consolidate its mainstream Medicaid managed care program, which is called Medallion 4.0, with its existing Medicaid managed care program for medically complex individuals, which is called Commonwealth Coordinated Care, or CCC+. Part of the impetus for merging these programs or consolidating them is to really address that bridge, those silos, and bridge those silos between populations who use long-term services and supports and those who don't. The state is going to streamline its model of care requirements for all populations to ensure access to care coordination based on members' needs and level of risk, rather than whether they use long-term services and supports or not. Other states, I'm going to talk about these quickly, North Carolina and California as examples, are increasing access to services and supports like housing navigation, medically tailored meals, and caregiver respite that impact and improve people's social determinants of health, like housing and employment stability, food security, and transportation access. North Carolina's Healthy Opportunities pilot, it's been in design for a couple years. Again, there was a little pause, I think, because of the pandemic, but it's going to launch this March in a couple months to test evidence-based non-medical interventions designed to reduce costs and improve the health of Medicaid beneficiaries. The pilots are going to provide up to $650 million in Medicaid funding for these services related to housing, food, transportation, and interpersonal safety and toxic stress in 3 regions of the state. And California, as part of the waivers I mentioned earlier, had authorized by CMS 14 what they're calling community supports, which are, again, medically appropriate and cost-effective alternatives to services covered under the Medicaid state plan. So these are going to be offered by managed care plans across the state and be offered at the managed care plans option and used at the enrollees, Medicaid managed care enrollees option also. And last but not least, for 2022, states are going to continue to develop and improve integrated care programs for dual eligibles, who are individuals eligible for both the Medicare and Medicaid programs. These are high need, high cost populations for both programs. I think they just, about 15% of both programs enrollment, but over 30% of these programs total costs. Right now, there's about 12 million dual eligibles across the country, and only about 10% of them are in a tightly, integrated programs that kind of look to integrate Medicare and Medicaid coordination and care management. So there'll be a lot of activity, I think, going forward in states across the country in really improving care models and experiences for those populations. 2 federal activities are going to influence states in this endeavor. Just about a couple weeks ago, January 6th, the federal government issued a proposed rule. It's really around Medicare Advantage plans, but among other things, it does focus on improvements in integration for dual eligibles who are served through a special type of Medicare Advantage plan called a DSNP, or a dual eligible special needs plan. And those plans are contract with states to coordinate Medicaid and Medicaid services across the enrollees who are enrolled in those programs. If those rules are implemented, then it's going to impact DSNPs, the dual eligible special need plans, in all states, including the 9 states that still participate in the federal, it was called the Duals Demonstration or Financial Alignment Initiative, because the rule is going to require the plans that operate in those duals demonstration to transition into these more integrated dual eligible special need plans with these new requirements under this proposed rule. Virginia and New York have already done that, and California is going to do that in 2023, move away from these what they call Medicare, Medicaid plans under the duals demonstration into these Medicare Advantage DSNP products. And more states are going to do that that are enrolled in the duals demonstration. Massachusetts is just finalizing its plans going forward for its dual programs. Texas, Ohio, Michigan, these states are really going to have to assess the impacts of this newer rule on their programming going forward. And then finally, MACPAC just last week discussed some recommendations it's going to bring to Congress in June about ways that Congress can better support state efforts to integrate care, either through requiring states to develop comprehensive integrated care strategies, and even providing federal funding that's tied to states moving in that direction. So more to come from probably many states in 2022 on integrated care programming for duals. And with that, I'm going to stop and just say the states are operating in a very dynamic environment, continuing to be influenced by the pandemic, but also heightened federal attention and investment in Medicaid, home and community-based services, as well as integrated care programs for dual eligibles, and just ongoing workforce shortages amidst a growing demand for these services. Thank you.
Okay, thank you for each of your opening comments. So we're accumulating questions in the and I'll start to walk through those in a moment from the audience. But I want to give you an opportunity to talk about a couple of other things, and also if there's any crosstalk that would make sense at this point. I'm going to ask questions about the state, but I'm also asking about employer activities. I'll look to Suzanne to speak to that, but of course anybody can speak to that if they have things to say. And Suzanne, you are free to talk about the states as you see fit as well. But I will be looking for Suzanne to always, take the lead on the employer. So here's a question. So if you think about the cost pressures, whether it's drug costs or whether it's the, say the hospital costs or the sector more broadly, these have been pressures on states and on employers for a long period of time. Anybody who's been around, around the blocks I've been around, I'm the oldest one here, I'm pretty sure, I've known this for a while. What would you say is driving the state interest? And is it things like some patient experience that catalyzes attention? Is it some behavior on the part of a hospital system? Is it some group in the state? What factors do you think are driving the attention and getting movement on these issues? And I'll tell you what, I'll just start in order, and I'll ask Maureen to go first, but we'll just work it from there.
Sure, and it's an excellent question. I don't think there's one thing in particular that was a catalyst for state action. I think it's a number of different things. I'll start with drug costs and prices and just share our experience with states. So NASHB actually does have an Academy of State Officials volunteering their time. We brought them together in, we bring them together often, but in 2019, 2016 and asked, what is keeping you up at night? And it was prescription drug costs. It came on the heels of the Hep C cure, which was amazing and groundbreaking, but incredibly expensive. And so at $1 million for a treatment cycle, it was taking over Medicaid budgets. And at the time, state officials, I don't know if they weren't paying close attention to the pipeline or if the actual price tag surprised them, but state budgets were truly being dominated in a way that they were not anticipating by this drug. And state officials across Medicaid and other health plans, state employee health plans and others did not want to be in a position to say, no, we can't provide you this life-saving, life-changing prescription drug. And so I believe that was an initial catalyst. And then as we've been working with states on prescription drug pricing, a number of officials came to us and said, so prescription drug prices are still something we need help with, but as we start looking at costs, we recognize that prescription drug costs are only about 9 to 10% of the overall health spend. And now we start looking at what else is driving these costs. And hospital and health system costs are dominant. They are over 25, 30% of the health spend. And then the next leading health spend is high cost providers. And then they look to primary care and behavioral health providers that need more of our healthcare dollar. And so I think there's a number of things driving all of this, but it really is states' attention to costs and looking at data that is spurring them into action in a number of different ways. And I'm sure Suzanne can speak to this more, but the other issue is high insurance premiums. It is something that individuals and employers are going to their state officials asking for assistance with, and there's only so much that can be done to further subsidize some of these premiums. So there is an interest to look at what's driving them in the first place, which is some of these high costs.
And Suzanne, you want to jump?
Yeah, I think that was a really great arc that Maureen shared. That resonates with my experience too, in terms of what has put cost front and center. You know, we as an organization have focused on the hospital side, you know, for over a decade now, sort of predating some of the specialty drug stuff and continuing through and with the specialty drug costs. So I think that's what caught the attention of the employers that we work with first. But also, I think that happened at the same time as a recognition that these high deductible health plans were just not good for low wage workers and for anybody but the highest paid workers. So I think the affordability issue is really what has sparked a lot of the desire for reform, whether it's payment reform, delivery reform, benefit design changes, network changes, et cetera. You know, we've gotten to the point where most Americans, you know, even with their health insurance, can't afford to use it. And I think that's just a crisis that a lot of people are hearing about and recognizing. What is fascinating to me, and I'll just pose like a challenging question to the rest of us, is, you know, employers have been saying that there's a healthcare cost crisis for the 20 plus years I've been working on behalf of employers to change the healthcare system. And even now, at such a crisis point, it's still only a minority that really take action. And the big question I have is, why is that? Is it because they don't know how, which we try to, you know, help with? Is it because, you know, their executives serve on local hospital boards? Is it because the healthcare industry in this country is so large that everybody is making some money off of it, and that maybe that revenue outstrips the rising costs of the health benefit? You know, it is a conundrum that, you know, for someone like me who has worked very closely with it for years, continues to be a mystery that I'm chasing the answer to. So affordability seems like a loud, you know, cry, but why is it that even with that, there's not more action taken? So I think it's so important that states are stepping in on this issue because, you know, some employers certainly do, but not enough to solve the problem.
Yeah, just a quick, you know, the Hep C event, I think, is a really good reference point for following up on Maureen's. And Suzanne, I also think some of the realization across people that I have insurance, but I'm still not protected is, you know, starting, and surprise billing certainly played into that. I've also, and you and I have had this conversation on the employers. I think the other thing on the employers is they realize that they may need government intervention, but then they don't necessarily, as an ideological point of view, want that. And so I think that's yet another barrier. We're going to move on with the question to Colleen, but I also want to do one clarifying comment here because it's come from the audience. There was a question around the 9-10% on drug spend, in a sense that that's a bigger number. And I think, and Maureen, you can address this if this is wrong. I think there's the NHE, the National Health Expenditures numbers, which part of the drug spending is actually housed in other parts of it, and the NHE number is really the retail pharmacy number. And I think those numbers are larger, more in the 15 and 17. And then, of course, as you go across markets, whether it's commercial, Medicare, or Medicaid, those percentages jump around. But I just thought I would clarify that because there was a question in the chat. And if I haven't done you any injustice, Maureen, I'll jump on to Colleen and move on to Colleen to, you know, what's driving the attention to these issues now.
Thanks, Mark. And yeah, just to concur that that's where I had pulled my number from too, is the National Health Expenditures data. And I agree with both Maureen and Suzanne that it's really hard to just pin down one thing that of what's driving these conversations. And truly, these issues aren't necessarily new. They just are evolving year over year. You know, new things come up, and how are legislators reacting to that? And then, you know, also Maureen brought up the Hep C example, and that was just on point. And I think just as costs and prices for, especially as we're seeing some of these newer therapies emerging, you know, they are life-changing, and, you know, like Hep C, in the case of Hep C, they save lives. But some now are reaching millions of dollars. And as I mentioned in my presentation, you know, Medicaid has to pay for those drugs. So I think that has renewed or heightened the interest in these issues. Plus, we're seeing constituents mobilizing in a way that we haven't before. You know, in the case of insulin, you know, constituents are making their voices heard about how detrimental some of these costs are to them. And especially as we're in a pandemic and with inflation and rising and all of those type of issues, I think people and states are particularly sensitive to fluctuations in price and cost. So that's something I would add on.
So we'll move to Stephanie to get her answer, and I just want to revise it a little bit for you, given the focus of your discussion. You know, the dually eligible complex care populations have been a huge problem for the states and the federal government for years, and there has been some sense of trying to move more towards integration and that type of thing. But what do you think drives the state interest now? And as you mentioned, there's some discussion of this in the new MA rule that's out. What do you think, you know, is driving the sudden interest in a problem that's probably existed for quite a while?
I think that's exactly right. I think these are long-standing problems. I said it early on about long-standing truths. I mean, these populations, I think the startling thing was how impacted, particularly in the early part of the pandemic in nursing homes, these high need vulnerable populations were impacted. It was just devastating. We all saw it, we all know it. And I think, you know, I've been working in this sector of healthcare for a long time now, and I think it bubbled up to the rest of healthcare. It goes to another truth I made around the siloing sometimes of the long-term care system from the rest of the healthcare system. I think people were just so startled about the devastating impact it had and on these populations, particularly living in congregate care settings and et cetera. So I think that was part of it, that it was just so startling to all of society. You know, people have known it who work in Medicaid or work in long-term care, but they've also known it if they have a loved one who might be, you know, living in a residential setting. But so I think that was part of it. And then, like you said, these are long-standing issues for decades where, and I mentioned earlier, the statistic about, you know, dual eligible populations, older adults and people with disabilities who are dually eligible being about 15% of Medicare and Medicaid's enrollees, but 30% and higher of their costs. So this is an area that states and the federal government have been looking to improve and figuring out ways to improve for decades around care management and care coordination. But it also goes to some of the discussions we had earlier about you know, value-based payments and where you can bring more long-term care providers into some of these value-based arrangements and better quality measurement in this space. I just think there's a lot more to be done in that space around purchasing and measuring quality and value in that space.
Okay, question, and we're going to move to the audience questions just momentarily. We have a few. So I want to ask you this. In the states, or and there may be an employer angle here, but this may be more of a state question. When they move on, say, drug reform or you know, the spending on hospital services or whatever systems, as the case may be, what markets do they tend to focus on? Do they focus on the commercial market? And if they're in the commercial market, is it the large employer, small employer, individual? Do they focus on the state employee? You know, let me put it this way. I have heard some states say we go to the state employee as our first place because that is under particular pressure, you know, given an appropriation. So I'm just curious, what markets do the states tend to focus on? And of course, you know, the answer could be it's all different in every state, but I'll at least pitch the question. And, you know, just I'm going to start at the top of the lineup again. Maureen?
Sure, I'm happy to take the first shot at that question. My understanding of where states direct some of their attention is maybe who the loudest voice is within the different markets. The other place that's just very strategic is where they have levers existing already. So for instance, thinking about Medicaid versus the commercial market versus the state employee market, which I know is already oversimplified, but thinking about those sort of three very broadly, states have different levers in each of those. And so identifying the problem, we often start talking with states about what is the issue that you're trying to solve, what does the best solution look like, and then how do you get there? And so creating some new levers is the hardest approach. Creating new regulations, creating new laws is extremely challenging for a lot of different reasons. There's usually a cost involved at the state angle. And then of course, there's also stakeholder pushback and addressing those different dynamics. But if there's a way that a state can use an existing lever to help them move in a more positive direction that guides a solution, that's where they want to start. That's where we often help them start. There's also something to be said for small but marked wins along the way. And so building up some momentum, as we've seen in the prescription drug space, has been extremely helpful. But then also realizing that maybe those smaller wins did not achieve their ultimate goal and being able to articulate where they need to go next. So I'm not sure that that totally answered your question, but it is different for different states and they do look at it very practically.
Suzanne, you want to jump?
Yeah, I mean, I'll just say that the state employee agencies that we work with all have different relationships with their state legislatures. Some of them are completely independent, except for the funds, and some of them have a much tighter relationship. So their ability to, the state's ability or the legislature's ability to influence exactly what they do varies. But we find state employee agencies to be among the most innovative and progressive purchasers out there. And I think it's in part because they have an actual budget, and it's not about just eating into margin or eating into profit. They have an actual budget, and they feel a sense of accountability, to the taxpayer. So we are thrilled to have them in our membership simply because they provide so many models for innovation and trying new things. So we definitely see states work there. Medicaid is an area that's obviously very complicated, but we also see the same with the Medicaid members that we have, that they've done extremely innovative things. They've been the first to do many things, I think, for similar reasons. Slightly different population, but overlapping with the commercial purchasers that we have in our membership. And what we don't see that often is a lot of collaboration across state agencies around some of the reforms. So you're like the state employee agency working with a Medicaid agency, or or other possibilities. So state employees are definitely at the forefront of trying to reduce spending and contain costs. And so not every state is there by any stretch, but there are certainly, I would say, 5 to 10 that really stand out as putting energy there.
And no, you're not required to, but Colleen, do you want to comment? You can feel free, but I don't want to put anybody on the spot.
Sure, no. So again, states only have the ability to regulate in a few different ways, right? First, they only have authority over state regulated plans, such as individual plans and those sold in the state exchanges. And then second, they can only negotiate prices that they pay for drugs in certain instances. So again, state employee health plans, but they can negotiate additional rebates in Medicaid, so negotiate supplemental rebates. So, but that said, I wouldn't say that states are focusing on any one particular strategy, and they're really coming at it, again, I can't stress it enough, that states are really coming at the issue of prescription drug access and affordability in a really wide variety of ways. And so, we consistently see legislators and states coming up with creative solutions to really try to ease that cost burden for both states and for their constituents.
And Stephanie, to you.
Just very quickly, I think I want to add on to something you said, Mark, and others touched upon it, just about how diverse the states are. When you look across the country in Medicaid programming and policy decisions, the states are so vastly different. So that whether it's politics or political philosophy around whether a state chose the Medicaid expansion, whether, the robustness of their Medicaid coverage of certain services, whether it's behavioral health services or et cetera. I live in Massachusetts. It's a very generous, Medicaid state, and it ends up being one of the drivers of what happens outside the Medicaid market in the state. So it does impact what goes on in the commercial space in Massachusetts. And so just that diversity around the country, it really is so state dependent about what is driving policy design across the markets in the state and where the levers are.
Okay, so what I'm going to do is I'm going to move to some audience questions and comments, but I want to tuck one question in your head, because if we get time, I'm going to come back to it. So I'm using my prerogative here. I'm also curious that, I was asking you what moves states forward. There is significant resistance to these changes when you think about the drug industry or the hospital associations. And what I'll want to come back to you if time permits is the notion of how states have been able to move through through that kind of resistance. So having many scars of my own, I'd be very curious to hear about that. So I want to move to some questions and comments. I'm going to first start with a comment, and I'll give a partial answer, but anybody else should step up. Someone in the audience is concerned, perhaps even agitated, that the Hep C pricing has been overstated, that it's not millions of dollars and that competition has driven the price down. Well, I am aware of that. I thought that the triggering comment from Maureen was more the question of when it started and what drew attention to the drug costs. And I know for myself, I had states all over me on how are we going to deal with this. And of course, the states took the approach of restricting access, and of course that raised all other kinds of issues. I think everybody on the screen is aware that competitors have entered and the unit price has driven down, although I don't think it's insignificant still for states to try and deal with some of the populations, and are often dealing with very large populations, even Medicaid prison populations. And so I think there's still concern over it. But I think everybody on the panel is well aware that the price has been driven down from launch. So I just wanted to make that clarification. Maureen, if there's anything that you want to add, or if I've mishandled that, please, revise.
That's exactly what I intended. It was the catalyst at the launch price of the first Hep C drug before there was competition. And Colleen noted Medicaid was in a situation where they had not as many resources to handle that, and disproportionately a lot of individuals covered in Medicaid who benefited from the drug, which created a budget issue in states that drew attention to prescription drug costs. Agree completely with
and that's how I took your comment. I'm sorry if anybody in the audience felt like we were unaware of that. Okay, so now I'm going to deal with a different question from the audience, and it sort of works like this. There is some concern that, and as you think about this, I mean, the audience question is pitched as drug list prices are the problem. And I would say there is a list price problem for sure. There's also a net price problem. We can, particularly as it relates to specialty drugs, brand drugs, which is where the pipeline is going. But that's the first clarification I would put on the table. But nonetheless, the question is, lots of the policy ideas that are being talked about here, and they aren't listed, but I'm going to say things like transparency, as an example, don't necessarily address price, that they are right. And so the concern is, I think the question is, are there policies to direct price? And there's also a further statement in the question that these things that don't directly affect price interfere with activities on the part of, say, a commercial payer or an employer. And I'd like to see if there's any reaction to that. And I've gone to Maureen as the opening batter a couple times, so I'm going to switch it up, and maybe I'll go just randomly to Colleen first, unless she says, no, I don't want to be first, in which case that'll be really awkward.
No, I liked the order we were going in. No, I'm happy to answer. So I think that's one thing that frustrates lawmakers, right? As we hear, oh, well, it's the list prices. Oh, no, well, it's the rebates from pharmacy managers. And then, the health plans are in there too. So there's a lot of this finger pointing going on. And I think that also, to kind of piggyback on the earlier question, is driving a lot of this momentum too, is that legislators are just, tired of the finger pointing, and they just want to get down to the nuts and bolts of how to affect drug prices and cost of, and affordability and access without all the finger pointing and the blame game going on. And so I think with the transparency laws, yes, they, don't directly impact prices, but again, they're being used as a tool to get into that data to figure out where exactly is the money going, what policy levers might be effective. And so I think that's what is driving some of those discussions and some of those policies for states, is just to get at that data and see exactly what the numbers are and where the money is going.
So way to be lead off batter, Colleen. I'm going to ask Suzanne to go next, and Suzanne, you can do anything you want, but if you have particular comments about when the states do this, it gets in the way of the employer, that would be a good thing. But you can take this anywhere you want to. That's part of the question, I think.
Yeah, I mean, at least the employers that I work with, well, I think they kind of fall into two camps. One is they're huge and they're fine working with the big PBMs because they know they're getting some kind of volume discount. And even though they know there's all kinds of shell games going on out there, they're just kind of counting on their size. So I don't think they are, too focused on what's happening externally. Then there are other employers who are just so sick of the game and not understanding it and feeling like there's so much complexity that they're purposely held at a disadvantage so that they can't uncover what's really going on. And, there's some move to, working with some of these smaller sort of upstart PBMs that are promising transparency, promising not to keep any rebates, et cetera, because they're, sort of offering a fresh alternative to the tradition. And so I think those employers tend to, be supportive of policies that are going to, hold this mess accountable. And I'm just saying this mess because there are many parties to it. So I think it's, employers are as diverse as Americans, practically as diverse as the states. There's a lot of different opinions, but I think those are sort of the two camps that I see.
And I appreciate you taking the employer point of view. Any other aspects of the question you want to comment on before I move on to someone else?
No, that's okay.
Okay, I don't want you to feel like you're being put in a specific lane. Okay, we'll go to Stephanie to see if she wants to comment on this particular question.
I think I'm going to defer to my expert colleagues on this topic about drug pricing.
No problem. And just so you know, I have an audience question that is going to come to you directly, and you will be the top of the lineup for that one. You're going to be just fine. It's not going to anything to worry about. Maureen, on this question, what would you like to say?
Sure. I think my fellow panelists and colleagues did a great job. I agree. Even in asking the question, hit on some of the complexity, list price, net price, rebates, and there are a diverse amount and number of rebates. There's also copay assistance. There's levels of prescription drug pricing, purchasing, that it's just very complicated. And I do think that states, when they were starting this, and some have been doing it for a very long time, so I don't mean to suggest that some just starting to look at this, but transparency was trying to figure out the complexity with the drug supply chain, where there were spots, where there were price changes, where there were rebate issues, where there may be spread pricing, where there could be opportunities to get some efficiency in what we already have versus going directly towards price, which is a very, very hard thing to do. And so I think as I noted in my comments, there's an evolution to the policy making and the levers that are being used.
Okay, I'm going to jump to a clarifying question. I think this is pretty straightforward. This is the one I was going to come to Stephanie first on. Someone in the audience asked for a clarification on what states are engaged in caregiver respite types of policies.
Well, so the two I mentioned as examples were California and North Carolina that are starting to offer these social supports that impact, again, people's social determinants of health. So those in California and North Carolina, those are being authorized through 1115 waivers through their managed care programs that serve their broad beneficiaries. But states have been offering some of these types of services, particularly housing supports and employment supports, through 1915C waivers for years. So I think at this point, almost every state, if not almost every state, has 1915C waivers, the home and community-based service waivers. And across the country, many of these programs, and now they're authorized through the Medicaid state plan, through these 1915I and K authorities, where you can provide a certain level of employment supports and housing support. So in terms of caregiver respite, respite is a service that's offered, is able to be offered through 1915C waivers. So I don't know exact number of which states, you know, most states have anywhere from, let's say, 2 to 9 or 10 HCBS waivers for different populations who use these services. So that service may not be offered in every single waiver, but many of the waivers do offer that service. And then now California and North Carolina are offering these services more comprehensively across the managed care program at managed care plan option to, you know, different types of enrollees in the program.
Okay, I'm going to move to a different kind of question in just a second, but I want to give anybody else an opportunity to jump in on the last one if for some reason if for some reason they would like to do that. Okay, all right, nobody jumped, so we're going to go to a different question, which is a question about the role of venture capital, private equity in healthcare. And I'm going to modify the question a little bit and say, do you have views on kind of positive, negative, that type of thing? And then the other part of the question is, should there be regulation of this activity? So I'll, that's the question. And I, as always, you are experts. So if you want to reframe the question a little bit, I'm perfectly okay with that. And I'm going to start, Suzanne, could I get you to go first on this? Are you good on this?
Yeah, I mean, I will not claim to be the deepest expert on all the perversions, that people have claimed venture capital and private equity to be responsible for. But I'm going to sort of twist it around in a different way, which is that the employers and purchasers I work with are very dependent on large incumbent health insurance companies to do much of what they need to do to procure healthcare services for their populations. And there has been so much consolidation among these, let's call them third-party administrators, because most of the big purchasers are self-insured, so they're not seeking actual insurance, they're seeking the administrative services that a health insurance company can provide. There's been so much consolidation, there's very little choice. And while very few of them actually have much market power in any given market, they do have market power when it comes to the limited choices that employers have and their ability to say, no, I don't feel like doing that. So if an employer wants to do something really innovative, they may not be willing to or be able to because of contracts that they have signed with providers. So to the degree that investment funds support the development of alternatives, alternative third-party administrators, ways to help employers who don't have the bandwidth to contract directly with providers, to have the ability to sort of do it in a semi-direct way with the facility of a vendor who's supporting that, I think that's a good thing. That's a very different topic from the role that private equity has played in high out-of-network prices and that sort of thing. But I just wanted to add that sort of twist to it that, the status quo isn't working. And so to the degree there's innovation supported by investment that brings other possibilities to the commercial market, that's good. I am not a fan of any nefarious practices that make it impossible for patients or those who pay for their care to do so affordably.
Maureen, do you want to jump?
I can, but I will be honest with you. I think this is a question that states have and that we need to know more about. I, for instance, know that we're getting questions about even like for versus nonprofit hospitals and health systems, and if that has an indication of quality of care, cost, price. And then there is, in those conversations, then private equity comes into play. And I don't know that, well, I know NASHP doesn't know the answers yet, but it's an area where states are very eager to learn more. And to Suzanne's point, I think everyone is open to innovation from wherever it comes from. So if that's part of the conversation, states would welcome that.
Yeah, I think in some of the issue is like there could be efficiencies gained. It's whether they fully pass through and whether the other side of it, the consolidation, drives the prices, even if there's efficiencies being gained over here in this pocket. Okay, we're at 126, so we're into the final stretch. So here's what I'm going to say to Stephanie and Colleen. If you would like to make a comment on this question, please do, but please be quick. I need to go into shutdown and tell people where they get additional information and all of that. But I don't want to close you out. So if there's some quick comments on this, I do want you to get them in. And so, Colleen?
I'll just make one quick comment that in the prescription drug space, I mean, we're seeing some newer entrants. We've seen like Amazon jump in, and we've seen, I think Mark Cuban is the newest person that's trying to make an impact. And I think, like Maureen was saying, I think that, states are open to where innovation might flourish. And, it's really kind of soon to know whether or not that's going to impact, competition, but we'll see, won't we?
Stephanie, quick.
Yeah, just quickly, actually in the home health care and nursing facility space, there's a huge infusion of joint ventures and equity investors in this space. So it actually played out during the pandemic it plays out all the time, but played out during the pandemic where in some cases there were concerns about accountability, where ownership had been changing hands, 5 times in 2 weeks, and there were benefits people saw by the infusion of cash. They were able to get PPE quickly and get their staff protected and patients protected. So it's just a big thing in the long-term care space, actually.
Good. I appreciate that, and I appreciate everybody being willing to respond quickly. So now I'm going to go into the shutdown. I don't get to ask my special question that I asked you to think about, but I would like to thank all of you for doing this and everyone involved in putting this together. I have a note here that asking everybody in the audience to complete their evaluations. I personally think the moderating in this session has been just outstanding, and so I'll just try and lead some people to that point. Also, there is a presentation on February 4th on FDA and user fees that you are invited. Oh, I'm sorry, maybe I'm going too fast, but everybody in the audience is invited to. And a recording of this will be available on the AHP website for people to follow up on. And actually, I might have done that too fast, but I think we're coming to the end here. And so I'll ask Maddie if there's anything else I should say or do at this point. And she just said, I think we're good. So I'd like to thank everyone. It's nice to meet you in those cases. Suzanne, it's really good to see you again. And I hope everybody stays safe and takes care of themselves.
Thank you
very much.
Thank you.